Okay, our first topic is infection is meningitis, which is the inflammation of the meninges of the brain and spinal cord. It's a medical emergency. The most important, so risk factor is patient is immunocompromised, malignancy, steroid, diabetes, HIV, acyplemia, overcrowding. Common organism, I'll let you know about the common organism in a minute when we discuss the treatment. But the signs and symptoms wise, patient will have fever, headache, and confusion. This triad is present in only 45% of the cases. So even if the patient has fever, headache, you will still consider meningitis. So fever is present in 74% of the cases, headache in 90% of the cases. They can have neck stiffness, inability to flex the neck forward due to stiffness in 70% of the cases. They can have petechial rash in Neisseria meningitis. Kernick and Brudinsky sign have limited sensitivity, just remember, limited sensitivity. And meningitis can cause complications like sepsis, seizure, DIC, adrenal hemorrhage, hearing loss, aphasia, hemiplegia, complications. I saw sepsis is common. Sepsis, seizure, they are common. Adrenal hemorrhage and DIC less common. How to make a diagnosis? History is important, most important actually, and you have to order LP before you give antibiotic. Rest of the studies can all be normal. So LP, take the history, get the LP, start the antibiotic if you are suspecting meningitis. So when you order LP, you will be ordering everything like culture, sensitivity, glucose, protein. You will check for intracranial pressure, gram stain and culture, leukocyte count. But beside that, you will order PCR for all the viruses, especially herpes simplex virus and varicella zoster virus. So there's a list of panel you will order for the viruses to confirm if the patient has herpes simplex virus infection or not. What are the contraindication to LP? So patient has raised intracranial pressure, bleeding disorder, they are on anticoagulation, or they have spinal cord abscess, spinal abscess. So when do you suspect meningitis? Opening pressure is high, 200 to 500. If it is greater than 600, then you should suspect hydrocephalus. Less than 600, 200 to 500, bacterial meningitis possibility. Leukocyte count, high in bacterial meningitis, 1000 to 5000. Less than 1000 is viral. Leukocyte will be predominantly neutrophil in bacterial, lymphocyte in viral. Glucose will be low in bacterial because bacteria eat sugar. It will be high in viral. Protein level will be slightly high in bacterial, less than 200 in viral. Gram stain obviously can be positive in bacterial 60 to 90% of the time. Negative in viral. Culture can be positive 70 to 85% of the time in bacterial, negative in viral. So you can also test lactic acid level, and if the lactate is greater than 35 milligram per deciliter, that will suggest bacterial meningitis will be negative in viral. So when you can do imaging before LP, raise intracranial pressure. If you're suspecting stroke, seizure, brain mass, get imaging first. And if the patient is immunocompromised, then you can also do CT brain first before LP. Treatment. So you'll give antibiotic plus steroid. Why you give steroid with antibiotic? Because antibiotic will destroy bacteria. When the bacterial cell wall is destroyed, that will release enzymes which will increase inflammation. To avoid inflammation, you'll give steroid. Give fluid, maintain electrolyte. monitor for signs and symptoms of intracranial pressure. Treatment. So it can be community acquired uh, versus healthcare associated. So community acquired means that patient came from outside, not from the hospital, and developed meningitis from home, or he was traveling. So it was not. It was in the patient was in the community, and the common organism involved are strep pneumo, Neisseria meningitis. These are the two most common organisms. Less common are H. influenza, Gubri, strep. Now, if the patient is immunocompetent, you will use cephalosporin. Why use cephalosporin? Because cephalosporin has good CNS penetration. CNS penetration. Why we add Vanco here? Because we are not covering MRSA. We are not worried about MRSA. Why we add Vanco here? Because there are a lot of strain of Streptococcus pneumo which are resistant to cephalosporin, but they are covered by vancomycin. So to cover penicillin-resistant strain of Streptococcus pneumo, we will add vancomycin, and then ampicillin for Listeria monocytogenes, especially if the patient is greater than 50 years of age. So this is when patient is immunocompetent. So you are covering strep pneumo, covering resistant strain of strep pneumo with oral vancomycin. You are covering Neisseria meningitis, and you are adding ampicillin for Listeria too. For immunocompromised patient, you have to cover Pseudomonas too. So you will do the same regimen, but for Pseudomonas, you will change third generation cephalosporin to fourth generation cephalosporin, which will cover Pseudomonas. You can see these guidelines on PubMed, and this is the ID. Now, if the patient is allergic to beta-lactam antibiotic, then at this point, I usually consult ID. ID need to be involved at this point. So for mild allergy, you can use just meropenem instead of cephalosporin. You will continue vancomycin, and because of ampicillin, patient is allergic, so you can use Bactrim for Listeria coverage. Severe allergy, you will definitely 100% you need to involve ID. So you can use oral vancomycin, IV vancomycin, moxifloxacin, aztreonam for Pseudomonas coverage, and Bactrim for Listeria coverage. But if the patient is allergic to antibiotic, ID need to be involved. Otherwise, you can manage on your own. Healthcare associated meningitis, let's say patient has neurosurgical procedure or ventricular drain placed in. This is healthcare associated meningitis after a procedure. In this condition, you will worry about MRSA and you will worry about gram-negative organisms. So you are worried about both MRSA and Pseudomonas. So if the patient has healthcare associated meningitis, vancomycin cover for MRSA, ceftazidime or cefepime for Pseudomonas, and then you will use meropenem too for or meropenem. So you can use vancomycin plus ceftazidime or cefepime or meropenem. So meropenem will cover everything. Ceftazidime or cefepime will cover Pseudomonas. Meropenem will cover Pseudomonas plus everything. Healthcare associated meningitis with severe beta-lactam allergy, ID need to be involved here and here too. You can use vancomycin, aztreonam or Cipro can replace cephalosporin, or you can use meropenem with severe allergy. So course of treatment during the hospital stay. So you send the LP, you will wait for culture and sensitivity data. And based on culture and sensitivity data, you will choose your antibiotic accordingly. So let's say if CSF culture is positive, you will change your antibiotic according to the culture. But if it is negative, it doesn't mean that you will stop antibiotic. So stopping antibiotic is not recommended with negative culture. If CSF PCR is positive for virus, then obviously no role of oral antibiotic. Then you'll give them IV acyclovir, and you can stop other antibiotic. But otherwise, let's say CSF culture is negative, then the decision is based on history, exam, and CSF result. And if CSF result is pointing towards bacterial meningitis, you will finish the antibiotic course. But in case of healthcare-associated meningitis, decision is challenging and individualized, and you need to talk to ID. So positive culture, change antibiotic according to the culture. Negative CSF culture, don't stop antibiotic, take the decision based on CSF result. And if it is healthcare associated, talk to ID. If no improvement in 48 hours, you can consider repeating LP. You can suspect resistance to antibiotic. You can repeat LP if fever for greater than 8 days.